Welcome to this module number 8 of e-learning from EAHAD. This e-learning is on Glanzmann Thrombasthenia and pregnancy. My name is Roseline D'Oiron and I work in Paris Bicêtre Hospital in France. I am an adult hematologist, but I also take care of children. This e-learning will be divided into 3 different parts. One will be on the state of the art. Then we will have a second part on clinical cases. And then we will have a third part on the most recent updates from the literature. So let's start with the first part of this module on the state of the art. When you look at the WFH data from the annual global survey showing the distribution of the different bleeding disorders, you see that hemophilia is representing the majority of them. Then you have the von Willebrand disease, and you have the other part, which is about 16% of all the included patients that are called the other bleeding disorders. Among them, you have the rare factor deficiencies. You have also the platelet disorders, which represent nearly 6% of the entire population with bleeding disorders recognized. Now, if we move to the Glanzmann Thrombasthenia patient, you see that about 3,600 people with this disease are recorded. And that represents only about 1% of the entire bleeding disorder community and patients included in the WFH annual global survey. The Glanzmann Thrombasthenia is a quantitative or qualitative defect of platelet membrane glycoprotein 2B3A, also called alpha-2B beta-3 integrin. Patients with Glanzmann Thrombasthenia are traditionally classified according to the expression and the functionality of this integrin, assessed by flow cytometry. Then you have 3 different parts. The type 1 is virtually absence of this integrin, below 5%. In the type 2, you have some detectable presence of this 2B3A, but significantly reduced between 5 and 20%. And you also have a qualitative defect called a variant type with nearly normal, a little bit lower, but above 20% of integrin, but dysfunctional. The diagnosis usually is done with a very specific test regarding platelet aggregometry. Indeed, the other tests of coagulation show normal PT, normal APTT, normal thrombin time, normal fibrinogen levels. The platelet count is, in the majority of the cases, normal or slightly reduced, and the size and the morphology of the platelet is normal. However, you have a prolonged bleeding time or closure time with the PFA, and you usually have a decreased and an absence clot retraction, even if this test is not performed on a regular basis nowadays. Looking at the aggregometry, you have an impaired platelet aggregation to all types of agonists like epinephrine, ADP, collagen, acid arachidonic, but normal with ristocetin. Mutation on genes coding for the GP2B part or the GP3A part of the integrin are both located on chromosome 17. Looking at the clinical findings now, the first manifestations usually occur very early during childhood and are mainly mucosal bleeding. Then you can have some excessive bleeding after trauma, dental extraction, surgeries, or deliveries. And you also have a very high clinical variability, even among the different people from the same family. They are not really dependent on the level of the integrin. These bleeding episodes are very often severe, and more than 80% of those patients with Glanzmann have a history of red cell transfusions. Sometimes these bleedings can be quite severe. The mode of transmission is autosomal recessive, so it means that you will have higher numbers where consanguinity is very important. There are a lot of unmet needs in this disease because there is no real access to prophylactic treatment. There is a very poor quality of life related to the repetition of the bleeding episodes. And there are a lot of difficult issues like how to manage heavy menstrual bleeding or how to manage gastrointestinal bleeding that may occur in those patients. In this map, you have the different rates of consanguinity per country. The darkest one shows the highest percentage of consanguineous marriages. And without any surprise related to the autosomic recessive transmission of Glanzmann Thrombasthenia, this is in these countries that you will have the highest prevalence of patients with Glanzmann Thrombasthenia. So this prevalence might differ considerably according to the consanguinity, and it can be only 1 per 1 million of inhabitants, but it could be also in other countries where the highest rate of consanguinity do exist, 1 out of 5,000 people. The principle of treatment in Glanzmann Thrombasthenia really relies on a lot of prevention, education, correction of the consequences of the bleeding episodes like correction of iron deficiency and anemia, early treatment of bleedings, and psychological support. Local and adjunctive measures like antifibrinolytics, fibrin glue, topical thrombin, electrocautery, or embolization can be really very helpful in order to limit those and stop those bleedings. And usually they are quite effective for a quite high number of bleeding episodes. However, sometimes it is not enough and additional adjunctive measures might be necessary, like hormonal therapy for women. Desmopressin is not really very effective in Glanzmann. It has been shown in some of the variant Glanzmann patients. Then, if the local and adjunctive measures do not work to stop the bleeding, platelet transfusion remain one of the standard treatment in order to prevent or stop bleeding episodes in Glanzmann Thrombasthenia. Because these situations might be repeated in life with the repetition of the bleeding episodes, it is important to try to prevent immunization against HLA antigens, and preferentially single donor apheresis are often preferred in when they are available and if it is easy to get them, which is not always the case. However, when you transfuse platelets, this might induce the development of isoantibodies against the missing integrin, the GB2B3A, and you may also have some alloantibodies against HLA antigens. And these might induce some clinical reactions and anaphylaxis after transfusion. It may also cause platelet refractoriness, and so impossibility to stop or to prevent bleeding episodes. And these antibodies, and we will see that mainly for the pregnancy, might induce neonatal or fetal thrombocytopenia. We will go a little bit deeper later in this talk about this problem. It is also important to note that even red blood cells, even when they are washed red blood cells, still may have some persistent platelet residues that may be the cause of this development of antiplatelet immunization and presence of antibodies against 2B3A. So when you have this situation of platelet refractoriness, the use of another hemostatic agents like the recombinant factor 7A might be extremely useful in order to stop the bleeding or to prevent bleeding in case of surgeries. After some case reports, then some few studies that has been performed, EMA approved this drug for those patients with Glanzmann Thrombasthenia and having antibodies against 2B3A and or anti-HLA, and or presence of refractoriness to platelet transfusion. In some countries, the prescription might differ and the approval might be different. After the EMA approval, it has been requested to still continue to collect data on the safety and efficacy of the use of 7A, and that has been the role of the Glanzmann Thrombasthenia registry to collect information on how were treated the bleeding episodes with the available medication and different strategies, either recombinant factor 7A and antifibrinolytics, either platelets, either recombinant factor 7A plus platelets, or antifibrinolytics alone. And you have in gray here the bleeding episodes and the percentage of success in order to stop the bleeding episodes with these different groups of types of treatment. And you see that these usually were quite good in terms of results. Regarding safety, during the follow-up of the Glanzmann Thrombasthenia registry, some reactions occurred after platelet transfusion, and there has been also some thrombosis related to the use of 7A that has been recorded after a laparotomy for ovarian cyst and hematoma. So in terms of choices to stop the bleeding episodes or to prevent bleeding episodes, in case of failure of antifibrinolytics or local measures, it was previously chosen to use platelets at the first line, and in case of inefficacy, to discuss 7A. However, we also can see not 100% of success with 7A, and sometimes reintroduction of platelets might be discussed as well. And it is also now, because of this problem of immunization against platelet, sometimes discussed to use 7A as first-line therapy. Let's move now to what happens regarding the women and the bleeding episode that they may have. Abnormal uterine bleeding are extremely frequent in women with Glanzmann Thrombasthenia. You have in this table some of the reports and the largest cohorts reported so far in the different literature. As you can see, the percentage of women having heavy menstrual bleeding were extremely high, except maybe this publication from Iran, where abnormal uterine bleeding might be quite taboo and maybe not recorded at the correct level. Now, when we move to the number of pregnancy, you see that these numbers in this entire literature are extremely rarely reported. And you have here, in all of these cohorts, the number of women who had some pregnancies and the number of pregnancies in total. And you see that the current available literature is really extremely rare. Indeed, when you have women with Glanzmann Thrombasthenia, usually they have abnormal uterine bleeding and sometimes quite severe that requires hormonal therapy. And usually we can control that with the combination of estrogen and progesterone. And sometimes we need to induce therapeutic amenorrhea in order to control those bleedings. But as they are doing quite well, there is always one day when those women would like also to have a pregnancy, and hormonal therapy discontinuation may lead again to resume to abnormal uterine bleeding. So it is sometimes very difficult to obtain a pregnancy because of this vicious circle. This is why sometimes in vitro fertilization or different approaches could potentially be discussed. What is important here is to note that the collaboration between the gynecologist and the hematologist is really crucial. It has been suggested that maybe women with GT could have an hypofertility that could explain this low number of pregnancies. However, they may have ability to conceive, and it does not seem that, contrary to afibrinogenemia or factor 13 deficiency, it is a real difficulty. However, the low frequency of pregnancies might be related to other gynecological issues like potentially impaired ovarian functions related to ovarian cyst rupture, or you also have this vicious circle leading to recurrence of abnormal uterine bleeding that really lead to iron deficiency and anemia that are very difficult to overcome. It is also very difficult for those women to deal with the risk of bleeding that might be a source of a lot of anxiety for her, but also for their baby. And there is also the guilty feeling due to the potential transmission of inheritable bleeding disorder. So this really represents a significant psychological burden. A lot of these women have been told when they were young that they probably will never have a pregnancy. There is also a lack of awareness of all of the options that may mitigate those risks. It is very important to inform those patients regarding their options, but also the limitations of the pregnancy. And to this regard, immunization against the platelet plays really a very important role. It is also important to inform about the risk of transmit the affected variants to the children. And here, the genetic testing and counseling is very important. Combination of joint clinics and multidisciplinary team is really key in order to help those women to see if conception could be possible related to their condition. Let's see in this slide what kind of genetic counseling could be shared with a woman heterozygous, so non-ill, but carrier of a variant that might lead to Glanzmann Thrombasthenia. As the transmission is autosomic recessive, for those women, it is important to acknowledge the risk of severe Glanzmann Thrombasthenia, that might be 1 out of 4, and to potentially discuss options for reproductive choices like prenatal diagnosis or pre-implantation genetic diagnosis. Now, what could happen in the genetic counseling of an affected Glanzmann Thrombasthenia woman and having a partner who is coming from the same community and some consanguinity, also carrier of the variant? Then you may have a risk of having an affected child as well. And here again, you may discuss the prenatal diagnosis and the pre-implantation genetic diagnosis, but you also have to secure hemostasis in case of these invasive procedures. However, if you have a risk of heterozygosy in the children, these can express some normal integrin in some of the platelets, and that could also be the case in case of a partner not carrier of the variant. And if the fetus is expressing GP2B3A, at least in some of the platelet, these can cause immunization issues for the pregnancy of the mother. So when you take first the risk of transmission of a severe form in case of consanguinity between the parents, if this situation has been eliminated, then if the fetus may express normal level of GP2B3A or at least 50%, if the parents are not consanguineous, those fetal platelets may cross the placenta and cause just like a transfusion in the mother with Glanzmann Thrombasthenia. And that might be the cause and the origin of either the appearance or the increase of the anti-2B3A antibodies for the mother. And this will make the management of the delivery much more difficult for these women. On the other hand, those anti-2B3A antibodies might cross back the placenta and cause thrombocytopenia in the fetus, and that has been reported to cause intracranial bleedings. The prognostic factors are not very well known related to the very low number of pregnancies that has been observed, but this has been clearly described in those women who had high level of anti-2B3A antibodies. The preventive strategies in order to avoid this problem is currently not related to very strong data, but maybe some strategies that may try to limit the risk of thrombocytopenia and bleeding can potentially be proposed. What do we know regarding all of these pregnancies that has been reported in the literature? A review has been published in 2011, and that was dealing about 35 GT mothers and 40 pregnancies. What has been observed was a very high increased risk of postpartum hemorrhage, not only primary postpartum hemorrhage, but also secondary late postpartum hemorrhage that could last quite longer, up to 8 weeks. There has been no maternal deaths reported, but multiple strategies has been described in order to cover the delivery, from platelet transfusion, 7A, plasmapheresis, red blood cells, immunoabsorptions, steroids, hysterectomies, uterotonics. Maternal immunization status was documented only in a limited number of patients and pregnancies. 10 out of 22 had positive antibodies against anti-2B3A antibodies and or anti-HLA at the start of the pregnancy. During pregnancy, it has been observed some increasing antibodies just only by the fact that it might be possible that a fetal transfusion was the cause of this increase of anti-2B3A antibodies. Regarding what happened in those fetuses and neonates, there has been 2 documented deaths related to intracranial hemorrhage that occurred at 24 and 31 weeks of gestation, both in strongly anti-2B3A immunized mothers. There has been 2 other deaths, maybe more ambiguous related to regarding the anti-2B3A status. One was a spontaneous abortion at 9 weeks of gestation. And there has been as well a thrombocytopenia in the context of hemolytic disease as well. But the mother has as well anti-RH and anti-2B3A and anti-HLA at the same time. There has been also some reported thrombocytopenia without bleeding in the neonates in 4 cases, and it has been to be recognized that only a limited number of neonates have been some records of their platelets, which is certainly a bias in all of these numbers. So to assess the feasibility and the risk of pregnancy, a comprehensive preconceptional process is required. For the woman with GT, there is an initial complete fertility assessment which is needed. You also need to know the status regarding antibodies against platelets. We need to know as well the history of platelets efficacy and the efficacy of 7A in order to stop bleeding episodes, and what is the tolerance of these products. You have to be aware that it is needed prior to go and embark to a pregnancy to have the most complete iron stocks and normal hemoglobin level. And you would like maybe to prefer 7A to treat the bleedings to avoid immunizations prior to a kind of a pregnancy. It is also important to have an assessment of the partner, and especially to have a semen analysis, not to cause any risk without any chance of pregnancy, for example, in case of azoospermia in the partner. And also to have some genetic counseling in case of a partner coming from the same community. Then you will evaluate the chance for having a pregnancy, to obtain a pregnancy, and what could be the risk not only for the mother, but also for the fetus regarding complications. And then, according to different stages, you may think that the chance is very low to obtain a pregnancy and that the risk is extremely high. and then potentially propose alternative options and psychological support, but no access to pregnancy. And in the other hand, you may have a limited number of patients, but where it could be a possibility that requires a lot of repeated clinics in order to explain all of the aspects and the options. But in that case, you really need to have some plans and to be honest with this couple about what will be the pathway and the journey until a pregnancy can be obtained. After that, some principles during and after pregnancy have to be observed in order to avoid platelets, to limit the isoimmunization, to make correction of the iron deficiency and anemia, and to have a very good oral health, not to cause chronic mouth bleedings that might lead to iron deficiency, to secure as well all of the bleeding risk, and to have for the delivery a multidisciplinary written plan that will cover all the different aspects of delivery. We know that there is an increased risk of postpartum hemorrhage, so long follow-up will be also required. Tranexamic acid certainly will be some help, but sometimes you will need to resume to hormonal therapy very early in order to control better this risk of postpartum hemorrhage. There was also, regarding all these anxiety regarding pregnancy and potential treatment, some psychological support in order to limit the risk of deterioration of the mental health. So in conclusion, this is a rare disease, and we have rare number of pregnancies in women with GT and little experience and data in the literature. So that's a very difficult challenge to obtain and follow pregnancy in GT women. And the role of immunization is really crucial, not only for the mother, but also for neonatal outcomes. So there is an importance to acknowledge that prevention strategies to limit immunizations are extremely useful and should be implemented, especially in girls and women with GT. And a lot of unmet needs will require further collaboration and research on that topic in order to improve the care for these women. Thank you for listening to this first part on Glanzmann Thrombasthenia and pregnancy. And I propose this first question for a quiz. What information on maternal risk can you provide to a woman with Glanzmann Thrombasthenia who desires a pregnancy? And you have multiple choices here. A, prophylaxis with 7A or platelets prior conception has been shown to increase the chance to obtain a pregnancy in GT women. B, high rate of maternal death from postpartum hemorrhage is repeatedly reported in series of GT mothers in the literature. C, bleeding episodes during and prior pregnancy may be preferentially treated with 7A to limit the development of antiplatelet antibodies. And D, iron deficiency is not a frequent issue during pregnancy. So the right answer is number C. Bleeding episodes during and prior pregnancy may be preferentially treated with 7A to limit the development of antiplatelet antibodies. This is particularly key in order to help GT women to have less complication as possible. The answer number A, there is no data showing that prophylactic treatment or platelet could help to obtain a pregnancy. However, when you stop the hormonal therapy, some treatment might be necessary in order to treat the abnormal uterine bleeding that may, and heavy menstrual bleeding that may occur. The answer B is not true. Indeed, there is no maternal death reported from postpartum hemorrhage. There has been some hysterectomies reported in GT, but in the literature so far, no maternal death reported at least. And the answer D, iron deficiency, is indeed an actually frequent issue during pregnancy. This is true in all types of women with bleeding disorders, but particularly true in GT women. Thank you with this part. And please go and see the second part of this e-learning regarding the clinical cases.